And now, to finish well our session, I have the pleasure of introducing Dr. Oumar Abdelhadi, coordinating physician of the National Tuberculosis Control Program in Chad. He's going to present to us the artificial intelligence for tuberculosis screening in Chad, challenges, opportunities, and impact. Dr. Oumar, over to you. Thank you. Thank you, Andrea, and thank you, Delft Imaging, who's giving us this opportunity of presenting what we're doing, the fight against tuberculosis, especially with the use of AI. Allow myself also to present to you my team who's going to accompany me from the beginning to the end, and they are here today to follow that presentation. We also want to thank Delft, who really helped us to continue and to have a strategy even when we had issues on the ground. We also want to thank Dr. Mosha, who helped us to better the quality of our presentation. And finally, thank you to the team who helped us to have this tool to do that. I will now do this presentation on AI for tuberculosis screening in Chad, challenges, opportunities, and impacts.
Next.
So our presentation plan will be on these points. We're going to have an epidemiological situation of tuberculosis, specific intervention, and some activity packages, and the screening. The results of active TB screening among nomads using AI in different key populations. So the nomads, in the detention center, in the refugee camps. We're going to talk about the challenges, the opportunities, impact, and then have our conclusion.
Yes, you want next? Next.
So, about epidemiology, you know that tuberculosis is one of the real health problems that we have here. In here, Chad, we have an incidence of tuberculosis that is estimated at 139 new cases per 100,000 inhabitants per the 2024 report. This, applied to Chad population in 2024, gives us about 27,000 cases of TB expected. But we're able only to detect 16,902 new cases, and that were able to be put on the treatment. And there's a gap of missing cases of 37%. We should also say that the 2023 cohort that was put in place helped us reach a success rate of 84% of cases successfully treated. About the collaboration for HIV and TB, we were able to test 93% of tuberculosis patients for HIV, and 8% were confirmed. Right now, we have 120 TB treatment sites with 54 gene expert machines, which help us to detect tuberculosis. So a good part of our centers are using those to detect TB. So if you look a little bit at the card of our country, the notification cases kind of change. It's more presence in the area where you have an easy access to health services, but also where the population is heavier. And so this is in our different regions, and most of the regions in the north and center have low notifications and rate, In the north, you have about 550 square kilometers. So it's not a lot of people that are living there. And they have higher chances of not reaching health centers. Therefore, we have a lower treatment there. And the interest of using that mobile strategy with the use of AI is therefore important to use them in those areas. Next slide.
Next.
Because of this problem, here are the specific interventions that we developed to address this difficulty. We developed a strategy to reduce the number of people missing from TB surveillance. And we, through financing, we bought a Delft truck equipped with an X-ray machine with AI for TB screening as part of a mobile strategy. We also identified key vulnerable populations and priority sites and developed, therefore, through X-ray, we're able, therefore, to detect. We also developed algorithms tailored to the key vulnerable populations identified. Next slide.
Next.
So to put in place this strategy, we had a strong involvement of the community and a collaboration also with prison authorities and administrative authorities to put in place the search for missing persons from TB. For this, therefore, we developed a number of deployments and health training centers of the groups that we mentioned. We trained 220 health professionals where you have more cases of tuberculosis in the 5 major cities, and we train also 90 nomadic health professionals around 15 health centers located in transhumance corridors. We trained 120 cell leaders from 12 detention centers to raise awareness about the signs of TB prevention, screening, and adherence to TB treatment. And then we trained 100 health workers in refugee camps in eastern and southern Chad to help implement that strategy. Next slide. So we had activity packages for community health workers that were put in place. We had raising awareness about tuberculosis. We identified people suspected of having tuberculosis. We referred to people suspected of having TB to TB treatment centers. We supported patients undergoing TB treatment. We searched for patients who had been lost for follow-up, and we had contact tracing of people who were confirmed TB. Next slide. So here are the algorithms that we use for those populations. Those algorithms are normally known in the different countries, and we had applied those algorithms. It starts, therefore, by a verbal screening, and then we do X-ray, etc. In the detention centers, we start doing by X-ray screening, and when you have signs of TB, then we do a test. But this is things that I'm sure you know already, and I'm not going to go hard on this. Next slide.
Next.
Here is the result of the different activities that we're able to do in those populations. Among the nomads, we really targeted 9 sites. 9 sites where they are staying in order to do the screenings for AI, for TB. Using, of course, X-ray with AI and also using the gene expert. So for those nomads, we recorded 667 people that were registered. They did a verbal screening, and among those who had the verbal screening, we had 200 that were suspected to TB cases, according to verbal screening, and when they were referred to X-ray. 207 who did X-ray, 20 people, so 9.7% of them had abnormal X-rays. And they were also referred to gene expert and did the test. And among those positive to do X-ray, 5 were confirmed TB cases that were sensitive and started treatment. Next. Among the detention center, as we said that the initial diagnosis starts with radiography, with X-rays, we visited the 12 detention centers. Among the 40 of them, we visited 12. And in those 12, 5,511 people received X-rays. They were screened with X-rays, and among them, 385 people, 7%, showed signs of TB according to the AI. 25% of those who had abnormal X-rays according to the AI were tested using gene experts, of whom 96 were confirmed. Next. About the refugee camps, we visited 9 camps in the center, north, and east of the country. This allowed us to do this work for 938 people registered. They had a verbal screening, and of whom 592 people, so 63%, were suspected TB cases who underwent X-ray screening. Among those who did X-rays, 75%, so therefore 12.7%, had abnormal X-rays according to the AI, and therefore they underwent gene expert testing, of whom 21 were confirmed TB cases. Among the 21, we had 7 that had a TB MR, multi-resistant tuberculosis, and 1 who had a pre-XDR. Next slide. And so together, during that period, we screened 7,116 people. Among those people who had the verbal screening, 6,357 had underwent checks X-ray, so an 89% of them. Among those who underwent X-ray, 589 people had an X-ray showing got cut off, had X-ray with abnormalities. Among those, so all of them underwent a gene expert, and 112 of them, therefore 19%, were confirmed by gene expert. And 1.6%, therefore, of registered cases. And all 112 of them were enrolled on treatment. So now what was the success and impact that we faced? You know that in our countries, X-rays is a luxury. And when we have that equipment and that is coming closer to the population freely, there's a real adherence of the key vulnerable populations, but also of the authorities, whether administrative authorities or penitentiary teams. This was really appreciated by the populations and the authorities. This was the first success we had. The second was also an important one, was that there was a real improved access to TB screening and diagnosis for vulnerable populations through the use of AI. Therefore, we quickly notified cases that we put in under treatment to stop transmission of TB of those key populations. Third success also is that we're able to improve TB data collection, especially among key population. Because in the past, we did not have enough information on those populations. And through that strategy, we can therefore have a better organization of those specific populations. Next. In terms of challenges, as my colleague was saying earlier in the chat, it's a big country. Chad is a big country. But unfortunately, our means did not allow us to have more than one truck that is equipped with AI-enabled X-ray technology. So as you can see, the whole part here in the north and center needed that. And needed therefore the use of X-ray technology with AI to increase the notification of cases. The other challenge that we faced was the limited capacity to renew the AI license. And here, we really want to say thank you and congratulations to Delft Imaging, because for diagnosis, we've always communicated with the Delft Imaging team, who really assisted us immediately. So despite the license ending, they still helped us to be able to continue to do the screening with AI. And for this, we're very thankful. Beginning of 2025, we were able to renew our license for 3 years. So we really want to thank this collaboration with Delft Imaging, which really helped us to continue that license, to not lose this diagnosis. But we also have a limited capacity to maintain the truck, because this is a specific truck, and even the equipment inside do not have any specialized people to maintain it. So that's a challenge. So we called Delft Imaging through its representatives in Ghana, and we tried to find solutions to continue to work for those populations. The other challenge, it's not the lesser, is that we had difficulty in resolving discrepancies between X-ray results and gene expert results. As you've noticed, on 589 people who had an abnormality in the X-ray through AI, only 19% were confirmed through gene expert. And here it was a real challenge. So to find a solution, we communicated with specialists to decide for whom we had to start the treatment. So our colleagues and specialists always stayed connected to us to answer. And about this discrepancy, it presents another question, because the results in themselves and the diagnosis through CAT4TB should be closer to the molecular diagnosis. But because AI has limits, our colleague as was saying, our colleague in Guinea, there's questions that are asked. Is there still a problem on the specificity of AI to diagnose TB? Is there a manipulation of gene experts who say that the results are different? There's a lot of questions. But still, there were questions that we had to to face, because sometimes they take gene experts with them, sometimes on the ground. So we should not have those discrepancies and try not to have them as least as possible, at least. But we still tried to put ourselves in the different situation of gene experts. And we still have questions. Why are there so many discrepancies between the X-rays and gene expert? I think our colleague from Guinea also said that it's things that are not tuberculosis sometimes, but they have the same symptoms and are recognized through X-ray as being tuberculosis. So this is a real question that we have to use to maybe better it, and how to also better our strategies using gene experts and X-rays. Next slide. As in opportunities, we really want to say that we have a prioritization of TB screening activities in the mobile strategy with use of AI, and that was a real opportunity for the health ministry. And that was really congratulated for its strategy. This is a real opportunity for us. The other opportunity is that the Global Fund, which is the main partner for the search of TB, has a substantial support for us in the search for missing TB cases. Next. As a conclusion, therefore, we keep in mind that the use of our AI for tuberculosis screening in Chad represents a significant advance in the fight against this disease. However, challenges remain and require special attention to ensure the success of this initiative. To conclude that presentation, I would like to say the use of AI with X-ray with AI is going to continue to better our use, and it can contribute, therefore, of this strategy that we want to end tuberculosis by 2030. I want to thank you for your kind attention.